Perfect. All right. Thanks for your patience. I apologize about that. So today you will hear presentations from Lisa Longfellow, who is the STD Director at the Louisiana Office of Public Health, and Amy Peterson, STD Program Specialist at the Michigan Department of Community Health. After hearing from our wonderful speakers, we hope that you will be able to describe how the school-based STD screening programs in Orleans Parish has evolved since its establishment in 1996, and how the Louisiana STD Control Program and their partners are working to continue to improve screening rates among youth. We also hope you'll be able to discuss why Guide to Implementing a Sexually Transmitted Disease School-Wide Screening was created, and how the Michigan school screening model has successfully expanded STD screening for school-aged youth with minimal overhead. And finally, we hope that you will be able to list common challenges encountered when establishing a school-based STD screening program, and describe key strategies in developing a successful and sustainable school-based STD screening program. So before I introduce our very first speaker, we have a poll that we would like for you to take. We want to know if you currently have a school-based STD screening program in your community. So go ahead and take time to complete that. I'll give you a few more seconds to complete it, and then we'll skip to the results. Okay, so we see that almost 40% do, and 60% of our respondents do not. So thanks for sharing. That's important to know when we speak for the presenters, when they present, to speak to the audience and really tailor their presentation. So now that we've covered the basics, I am going to introduce our first presenter, Lisa Longfellow. Lisa Longfellow is the manager of the Louisiana Office of Public Health's STD program. She is responsible for the state's STD surveillance, clinical, and prevention efforts. Ms. Longfellow has over 26 years of experience with the Louisiana STD and HIV programs. She received her Master of Public Health in 1989 from Tulane School of Public Health and Tropical Medicine, and completed her undergraduate studies at Northeast Louisiana University. Lisa, the floor is yours.
Well, thank you very much, and if y'all can't hear me, let me know. I'm very pleased to be here. I wanted to start by telling you or reviewing for you that Louisiana has some of the highest rates of gonorrhea and chlamydia in the country. We rank number 2 for gonorrhea rates nationally and number 5 for chlamydia rates. And this slide shows you the gonorrhea cases among 15 to 19-year-olds. So we have a lot of morbidity in our state, and this is why this program is so important to us. We've been very fortunate to have screening in Louisiana since the 1995-96 school year, and it's been conducted by the Louisiana State University School of Medicine in collaboration. Okay, I see that I'm hard to hear, so I'm talking right into my phone, y'all. Keep telling me if I'm not doing very well. So our screening program started in 1995-96 in collaboration with the Office of Public Health and the Louisiana State University School of Medicine, funded by CDC for the first 2 years, 75%, and the screening program continued for over a decade, really up until Hurricane Katrina. It was a school-wide screening event program where a team would go into the school and obtain consent from the students for participation. These would be consent forms sent home to the parents or guardians if the child was under 18. And if they were over 18, they could provide their own consent. During the testing period, classes would be escorted one class at a time to the testing area, which could be a hallway near the restroom. It could be an auditorium, a gym, or a vacant classroom. Each eligible student is counseled individually regarding the opportunity to participate in testing, and if their parents did not provide consent, then they were sent back to their classroom. Those who did consent and wanted to participate were given a urine cup and asked to collect the sample, and the samples were delivered to the laboratory on the same day for an amplified testing. Then the results were brought back and counseling and treatment was provided. Under standing orders, the school nurses provided treatment and counseling to the infected students, and the students were asked to seek an additional STD exam and HIV testing with their physicians or at our local STD clinic. They were also asked to refer their sex partners to the local clinic for treatment and other STD testing. And if the partner was at the same school, then they could be treated at the school by the school nurse. Of course, confidentiality is a major concern, and the students, we wanted the students to not be singled out whether or not they were tested or not, so every child who had a consent form was given the sample and a brown bag and the opportunity to go in and provide a sample or not and return the brown bag to the counselor so that the other students wouldn't know if the person was tested or not. The specimens were labeled with code numbers, and when the results were available, they were returned to the students individually in sealed envelopes in the early years or through an automated voice system since 2000. We never gave results to parents. If they wanted to know the test results, they needed to get it from their own child. This program started with 3 schools, and during those first 2 years, the testing was done twice a year, in the fall semester and the spring semester. After that, testing was only done once a year, but the program was expanded from 3 schools up to 13 in the highest year and 9 in 2004-2005, which is when the program kind of ended because of Katrina. And somebody wants to know about the response from the telephone automated system. I am very sorry, but I don't know that answer, but I can get it for you. And this shows you the prevalence of chlamydia in the 9th through 12th graders who were tested, the percent positive by gender. It ranged from a little over 4% in the males in the lowest year and up to about 9% in males in the highest year, and the highest prevalence in females was a little over 16%. Now, around 2000 is when we switched to the nucleic acid amplification from the, I think it's called LCR. So that could explain a little bit about the big increases you start to see right there. Okay, standing orders. Someone wants to know about standing orders. These questions are great. So in our clinics, if a nurse has an agreement with her doctor that if there's a positive test for gonorrhea, she should treat with a certain medication like ceftriaxone, then she doesn't need the doctor there to sign off on the chart. She just does it. And the tests were done at the LSU laboratory, to answer another question that I see. And we treated based on the positive test. There was not an additional exam. And we did not have the ability to do oral or rectal tests to respond to another response that I just saw. Okay, now Lynette is asking a really good question. She wants to know what percentage of students participated. And that was about 50% of the students who were eligible actually participated. And there are lots of articles published on this, and I have a list of them in the presentation for you. But one of the articles I wanted to talk about specifically talks about missed opportunities for early detection of chlamydia and gonorrhea in school-based health centers. And the authors are all from LSU, and it was published in the Sexually Transmitted Diseases. And it talks specifically about during the 2002, 2003, and 2003, 2004 school years, they compared utilization of the school-based health center in 3 of the schools that were doing this school-wide screening but also had school-based health centers. And the participants were asked if in the last 90 days they had been tested or treated for an STD at their school-based health center. 9.8% of those that were screened in the school-wide screening had also been tested at the school-based health center. But overall, 13.3% of the students tested positive for chlamydia or gonorrhea. And of those who tested positive, 53 had not been tested or treated at their school-based health center. So the conclusion from this article was that many infections could have been detected by testing students during routine visits in school-based health centers, that the lack of routine screening in the health centers represents a missed opportunity for early detection of chlamydia and gonorrhea among local teens. So about 2004, we started encouraging school-based health centers to screen for STDs. And this just describes the enrollment process for school-based health centers. The parents consent to whatever services are available at the school-based center. They do not need to give an individual consent for STD testing. Once the student is enrolled in the health center, they can take advantage of anything that's provided there. And we have approximately 60 school-based health centers across the state in either elementary, junior high, or high schools. So as I mentioned, in 2004, we started making testing available to the centers. Unfortunately, 2005 wiped out our ability to do amplified tests in the state lab, and LSU did pick up at least the testing for symptomatic patients. We also kind of had a devastation of schools in Orleans Parish, so we really haven't had any broad screening programs in schools since then. Now, in 2007, our state lab did get the ability to do amplified testing, and we again started to encourage school-based health centers to screen all sexually active patients annually. And in 2009, it was actually incorporated into the contracts for the high schools that they should provide an annual screening of gonorrhea and chlamydia to all sexually active patients. Because that's one of the barriers. If the school-based health center can say, well, we have to do it, it's part of our contract, then they can get by the, what do you say, the resistance from school administrators, parents, anybody that doesn't want all the kids to have that opportunity. Now, this is brand new, so we're seeing, and what I have here are the 2009 results. So this is calendar year 2009, which only includes the first half of the school year. But we have had testing done in 32 senior high schools across the state. And as of December, they had submitted 912 tests, of which 112 were positive for chlamydia. I didn't include the gonorrhea positivity. The number of tests submitted by each site ranged from a low of 5 to a high of 214. So it looks to me like some of those schools are just doing a diagnostic test, and others are actually trying to test all the students. And if they do test positive, then they are treated there at the school in the clinic. The STD program pays for the testing and for the treatment, but not any staff time. That's provided through the school-based clinic. Since we thought the numbers were a little bit lower than we would have liked to have seen, we started trying to increase the screening, and here are the efforts that we've made so far. First, we incorporated the requirement into contracts. Then we actually surveyed each of the sites to find out exactly who they were testing, what barriers they saw to their testing, and their ideas for increasing the rates of testing. One of the barriers was that some of the staff still believed that they needed the parents' consent for the test, and there were also others who still had some opposition from the principal or other school administrators. So what we did next was actually a presentation to the providers at their annual meeting this past summer to share what we had learned from them, from the survey, and the testing results, how many tests they had done and what the positivity had been. And then actually today was the next step in that process. We started a series. LSU School of Medicine is holding webinars on STDs. It's going to be 2 hours a week for 3 weeks, and then once they've completed the webinar, they'll actually go to an STD clinic in Louisiana and observe so that they can see signs and symptoms and really feel comfortable with STDs. And there's a question about paying for tests for males, since CDC only recommends testing girls, and we're using state funds for that. And so far, we have not run out of money for testing. And the staff at the school-based health centers, they all have a nurse practitioner. Most of them have mental health staff too, but it's the nurse practitioners who administer the medication. Some of them have RNs who may be collecting the samples. I mentioned that there are a lot of publications from the school-wide screening program, and this is a list of them. If you're thinking about starting this type of program and you need some documentation to take to your administrators, to say this is a great idea, we want to do it in our state or in our city, and you want copies of any of these letters, Dr. Swami has been very generous to say that he would be happy to send them to you. I do want to acknowledge everybody who's involved in this project. We have had a very dynamic team here, starting with Debbie Cohen, who had the idea, Dr. Farley, who helped her get funding for it, and Dr. Martin, who processed the test in the LSU lab, Dr. Taylor and Dr. Swami, who actually went out to the schools to do the testing, and from our adolescent school-based health program, Maureen Daly, who was the original manager who wanted the screening done in the school-based clinics, and Maxine, who's continuing to support the program, our infertility prevention project staff, team members from family planning and the lab, as well as STD, and our STD staff here, our epidemiologists, Mallory and Mohammed, who make all this data analysis easy for us. So, y'all have had some great questions. I tried to answer them as I went along, and I think there's going to be another opportunity for questions at the end. And here is Dr. Swami's email address if there are specific articles that you want copies of. And somebody is asking more about school-based health centers in general, so that'll be a different conversation. I can send you a link to the website that talks about those. And now I am going to turn it back over to Sandra.
Thanks, Lisa. Given how long your screening program has existed, you've certainly had plenty of insight and useful information to share. So thank you for taking time to do that here today. Our next speaker is Amy Peterson. Amy Peterson has 17 years experience in HIV, STD, and public health. She has worked in a number of roles at the Michigan Department of Community Health since 1996. Since June 2007, Ms. Peterson has been employed in the STD Section as the Infertility Prevention Project Coordinator, where she has been instrumental in the development and implementation of the state's Gonorrhea Chlamydia Reduction Plan. The plan focuses on increasing appropriate screening, retesting, and treatment for young women and their partners in the public and private sectors. Ms. Peterson received her Master of Public Health in December 2003 from Tulane School of Public Health and Tropical Medicine and completed her undergraduate studies in minority-majority relations at Michigan State University. Amy, thank you for joining us.
Thank you very much, and thanks for that introduction. It feels a little formal, but I'm very happy to be here, and thank you for everyone who's made the time to be here as well. I'm going to start kind of where Lisa did, and that is just to ask if people are able to hear me, and if you have any problems, to go ahead and jot a note into the chat, and I will try to adjust accordingly. The presentation that I'm going to be doing today really is a continuation and a dovetail with what Lisa has presented, because we're doing some similar things here in Michigan, and we're also going to be talking about kind of how we have mixed and mingled some of our strategies between doing school-wide screening and then school-based health center screening, and how those seem to fit together here in Michigan. I want to acknowledge before I get started too far down here is that I'm not sure if I'm going to be as good as Lisa was about being able to read those questions and respond to them along the way. So if not, I will make sure that I attend to the questions when we're done with the formal presentation. All right. So to get us started, I want to give you just kind of an overview of what we're going to be talking about today and what's included in my presentation. First of all, I'm going to give you some background about the morbidity here in Michigan, then talk about our Michigan IPP Alliance and who it is made up of, then discussing our IPP screening in Michigan, because the screening that we do in schools is really a subset of what we do in other public sector sites. Then I'll talk a little bit about our GCCT reduction plan, which is a 8-component plan to fight chlamydia and gonorrhea in our state. Then I'll discuss specifically our screening document, or what I call our Blitz guide, which is a document that we put together to help areas or jurisdictions do school-based screening in a Blitz format. Then as I'm finishing up, I'll talk about some successes and challenges we've had with that, and then what our plans are here in Michigan for going forward. So to set the stage about gonorrhea and chlamydia here in Michigan, in 2009 we had over 48,000 cases of chlamydia reported, and 42% of those cases were in the age group of 15 to 19. Likewise, we had over 15,000 reported cases of gonorrhea, and 34% of those cases were in that age group of 15 to 19. So we definitely see our school-based health centers, where we have an audience of that age group, as an important partner for us. So speaking of partnerships, I just want to identify what happens here in Michigan regarding our IPP Alliance. While we send representatives to our regional group, our Region 5 IPP group, we also have an alliance, a statewide alliance that meets specifically here in Michigan and is a little bit broader. We meet on a quarterly basis, and this body includes representatives from our STD, Family Planning, and Bureau of Laboratories. But we also have some other partners who come to the table at those quarterly meetings, and that includes specifically our MDCH Child and Adolescent Health Center program and representatives from that program. We also have individuals who represent juvenile detention facilities, and then we have a contract with Oakland County, which is one of our largest health jurisdictions and most populated health jurisdictions here in the state. And they do some specific screening and corrections, and also in school-based health centers in their county. And so they come to the table to share their information and what's going on in their programs. So at these quarterly meetings that we have within our state, because we have the Child and Adolescent Health Center representatives at the table, we think that that's really key, because we are able to have a shared vision and a shared view of what should be happening as far as screening goes, and particularly we're able then to kind of influence each other in who we screen, how we screen, and what our priorities and policies will be. So IPP screening overall, in Michigan, our IPP screening is a combination of various funding sources. We have, of course, CDC IPP funding. We also do have state resources that support some screening tests. And then our adolescent health partners and our family planning partners also put additional dollars in the pot to allow additional screening in their venues. In calendar year 2009, across all public sector sites, we did 106,000 tests for chlamydia and found about 10% positivity, and again, that's across all IPP sites. And we did just over almost 92,000 tests for gonorrhea. The reason there's a difference is because here in Michigan, in our very rural areas, we do primarily chlamydia-only testing, and then the combo tests are used in the rest of the state. Our gonorrhea positivity, we identified 3.3% positivity in 2009, and that is down significantly. In 2007, our positivity in IPP sites was 4.9%. So we do believe, knock on wood, that we're seeing a reduction in gonorrhea in Michigan, and that does seem to be holding in the public and private sector, thankfully. Collectively, our IPP sites diagnose 22% of the state's morbidity, with the remaining being identified in the private sector. The question popped up, do you get significant savings from the CT-only screening? As a matter of fact, we save about $1 a test on those CT-only tests, and they do represent a very much a minority as far as the number of tests that we run in the state. So there is a bit of a cost savings, but more importantly, we also see it as an opportunity to avoid any possibility of false positives, which we, again, know is a reduced risk, but it is a reality and a possibility. All of our program sites do have the ability to do combos on anyone who's symptomatic or feels that they have any potential exposure to GC, but we do, again, allow the CT only or support CT only in our very rural areas. We have counties that have had 0, 1, or 2 cases of GC in the last couple of years. So those are the areas that we're looking for, and in very low numbers. All right. So to talk about kind of our screening sites and the different IPP program sites that we're doing screening in, as you can see here, I've just highlighted some of the most common provider types that we see in our IPP data set. And all of our IPP tests are run through our State Bureau of Laboratories, through our regional lab system, so the data comes into a single data set. If you look at our provider types, we have 2 that I've highlighted here, the school-based sites and the teen clinics. And at first blush, it may be like, so what's the difference between the 2? And I'm going to take a couple of minutes and try to describe that to you, because it is particular and specific here in Michigan, and an important distinction to be made. School-based sites, as it's listed there, those are sites that have been designated what we call a screening site, meaning we have asked them to screen, to test every sexually active student who comes in, regardless of reason for visit. Those those school-based screening sites, there are 12 of them, or there were last year. We're actually increasing that this year. And they sometimes vary from year to year because of sites coming on or dropping off. They may have closed a clinic. But these are sites that are either in a school or are linked to a school, and that we have a special relationship with. We have designated them as screening sites. Because they're screening sites, they receive a larger allocation of prepaid test requisitions, which is how we control kind of number of tests and availability of IPP tests here in Michigan. So in 2009, in those 12 school-based screening sites, they did 2,700 tests and found 382 positive chlamydia, averaging 14.1% positivity. The second provider type that's highlighted there are teen clinics. Those teen clinics are school-based or school-linked health centers that have not been specifically designated as screening sites. They are what I consider more likely to be test sites. They test youth who are either symptomatic or who have clearly identified high risk factors, multiple partners, partner of a person who's had an STD, a history of an STD infection, maybe someone who's coming in for a pregnancy test. So those sites are doing much more symptomatic and high-risk testing. And in those sites, that actually represents 25 clinics in 2009. And they did a collective 3,000 tests, finding 441 positives, or 14.7% positive. And it makes sense that their positivity would be slightly higher than the screening sites because they're testing far more symptomatic cases. And so they are kind of, picking those who are most likely to be positive and testing them. So again, here in Michigan, we make this distinction between a screening site and a testing site, even though they're all adolescent sites. And the question is, are these female tests only? And the answer is no. And again, we're able to do that because of the combination of funding that is both federal and state, as well as some supplemental funding from our adolescent health partners. So this just kind of dictates out what I was just saying about the different types of sites and how they are given direction. What I would like to point out is something that I missed, and that is that in our screening sites, in those 12 screening sites, those sites are in high morbidity geographic areas. We did at one point, I believe it was in 2008, had identified a site that was in a more rural area as a screening site. It was kind of a test case for us to see what would happen if we truly screened in a more universal way in a rural area. Would we find chlamydia or significant chlamydia in that population? And what we found is the answer was no. We screened more students in that school at the time, and we just did not find disease. And so we backed them back to what we call a test site because it wasn't a cost-effective intervention to leave them as a screening site with the direction to screen basically all presenting youth who have had sex. And again, our test sites are scattered throughout the state, and they are in mixed morbidity areas because they represent other high school, primarily school-based health centers. There's a question about, do these results or the screening sites just reflect asymptomatic patients? And the answer is no, and I'll talk more about that a little bit later in the presentation. All right. So the next section of my presentation, I'm going to talk a bit about Michigan's GC reduction plan. In 2007, shortly after coming to the program, we were doing some kind of brainstorming and problem solving and trying to figure out, if money were no object, what could we do, what should we be doing in Michigan to bring down the disease prevalence around GC and CT, and what, again, would we do if we had all options on the table. And so what we did is we created what we call the GC-CT reduction plan. That reduction planning is an 8-point plan. It has 8 components to it, and each of those components have some subsets to it. But expanding or increasing school-based screening was an important component of that plan. The bucket that you see represented here on the slide was kind of our visual cue for the project and for the plan. Because what we were acknowledging and what we were trying to fight against was that from 2002 to 2007, our morbidity in Michigan had been very stagnant, it had been stable. And so while we were removing infections from the population through identification, diagnosis, and treatment, we were having an equal number of new infections occurring at the same time. So basically the spout going into the bucket was just as vigorous as the spout coming out of the bucket. And so we were trying to put heads together and say, what could we do to, if you will allow me to quote, we said, what can we do to poke holes in the bottom of this bucket so we can get it to drain faster? So we're removing infections from the communities at a faster rate than new ones are being transmitted. And so again, this plan had 8 components to it, or it has 8 components. I speak of it a little in the past tense because in 2008 we were awarded, we had gone to the state legislature and done some education and testimony at their invitation, and they had actually granted the STD program supplemental dollars in the amount of $750,000 for 2009. Unfortunately, about 6 months later is when the bottom dropped out of the whole economy at the national and statewide level, and so that money went away. It was one of those, like, easy come and easy go. So we had it for a very short period of time. We were able to do a few of the initiatives and plans that were a part of that, but we had to do a lot of them in kind of a quick and dirty manner and not with as well thought out and as well planned as we had hoped to do. Because when the original allocation was made by the state legislature, it was actually for 5 years, and that's how the plan was written, as a 5-year plan. We have continued many of the components of that plan, and we're pushing them up the hill, although they've had to be scaled back and reduced because, again, we do not have those supplemental funds. We have not had them for about the last 18 months, and so we've just been trying to do what we could. But it was a great exercise in helping us to actually sit down and to think creatively and to plan, and to bring our partners on board with that as well to help us, because we were kind of doing kind of the same thing over and over. And so, again, some of our school-based screening planning is a piece of that. So I'll focus on that. So included in the GC-CT reduction plan, we identified 3 ways that we wanted to increase school-based screening here in the state of Michigan. And the first one was to increase coverage in our current screening sites, so increase the proportion of the student bodies in those schools that were being screened. The second one was that we wanted to select new sites that were on that testing list or in that testing group and switch them to screening sites to increase their ability to screen more holistically, but to do that in a very selective way, which I'll be talking about. And then the third one was the development of our Blitz guidance, to expand the possible sites and partners who could do school-based screening. Our current school-based screening was limited only to sites that had in place a school-based health center, and so the Blitz guidance was provided or created to try to expand that possibility to schools that may not already have a school-based health center on site. Sorry, I'm trying to read the questions at the same time. I'm just not good at it. Okay. So as far as the first strategy of coverage in the screening sites, When we do analysis of coverage, when we look at what is the size of the student body and then what is the size or the number of people who are being tested by site, when we do an average across those 12 venues, we see that we're averaging around 20 to 24% annually of the student body is being screened. And again, that's the average. We have some schools who are screening 80%. They may have more of a Blitz type approach. And then we have other schools who are, despite being designated as a screening site, may only be screening 5% of their student body. But again, the average is around 20 to 24% of the student body. Just by raising attention to this and raising awareness among our sites and working with consultants that we have designated to work with these sites, in 2009 we did see an increase in both the number of tests in these screening sites, and thankfully at the same time that we increased the number of tests, we also saw an increase in the percent of positivity. And while that may sound like an odd statement, like we're excited that the positivity is up, when we increase this number of tests, we expect that the positivity may go down a bit because we're screening a more broad group, but the fact that the positivity actually increased told us we really do need to be screening more in these sites and getting a more broad-based approach in these schools because they've got a lot of disease and a lot of morbidity. Some other great things about these school-based health sites and the consultants that work with them is that they do have a 99% treatment rate for cases that are identified in these sites. And 60% of the individuals who tested positive provided partner information to the staff of the sites for follow-up or brought a partner in with them. Now, we expect that there are other students who have tested positive who may tell their partners themselves or may send their partner to the local health department for screening and that we're not aware of kind of in this data. But even saying that, 60% having provided partner information to the site we thought was a positive piece of the puzzle to controlling disease. The question is, does Michigan allow EPT for teens? And the answer is no. EPT is still currently illegal in the state of Michigan. We have laws on the books that state that a physician must have a relationship with a patient to provide them with medication. And so to date, we have not changed legislation or language to be able to have EPT here in Michigan. So why is it so important to be a screening site, and why is it so important to screen holistically in these sites and to screen all students who present regardless of reason for visit? This slide is, to me, kind of the bread and butter of our screening projects and why, as Lisa was talking about, encouraging school-based health centers, particularly in high morbidity areas, to screen holistically and to screen students regardless of reason for visit. This slide represents positivity in the screening sites. This is 2008 data. It looks very similar from year to year. But if you look at this, this is the positives. What did they come in for? Of those who tested positive, what did they present for? And although those who came in for STD check and for pregnancy tests represent a large proportion, there's also many people who tested positive who came in for another illness, who came in for a school physical. Immunizations often falls into that other category. And collectively what we saw was that 51% of the infections would have been missed if the sites were only testing students who presented with an STD request. So again, I think that's really a telling statement. All right, so speaking about symptomatic and asymptomatic disease, we do find a ton of asymptomatic infection in our school-based health centers, and it really has helped us to make the case in using our state resources for male screening and expanding male screening, particularly in this young population, because we see so much asymptomatic infection among males and females. This slide represents positive chlamydia and whether they had symptoms or not. Of the males who were positive, 55% had no symptoms, and in the females, 60% had no symptoms. So over half of both males and females with chlamydia who tested positive in our school-based screening sites had no symptoms. Similarly, for gonorrhea, we see that males, of course, with gonorrhea, and not surprisingly, were more likely to have symptoms. But still, 25% of the males who tested positive for gonorrhea in our school-based sites had no symptoms, and over half of the females with gonorrhea had no symptoms. So again, it speaks to the importance of screening rather than waiting for symptoms or signs to do a test. So what are some of the strategies that we have used to increase coverage in our school-based health centers or our child and adolescent health centers? Excuse me. I want to acknowledge that, again, because of our relationship with our school and adolescent health center program, we are particularly lucky here in Michigan. They do the legwork with these sites. They also have hired a consultant who specifically works with the screening sites to make sure that their questions are answered, that they have the supplies that they need, that they receive feedback so that they kind of know where they stand with their screening, and those resources have been invaluable to us as an IPP program or as a chlamydia gonorrhea program at the state level. Those consultants, both from the Adolescent Health Center program itself as well as the consultants that they work with, provide one-on-one visits to the sites and encouraging them to screen broad-based, and again, just kind of providing them with feedback on that, because even though the direction is given that they are to screen and that you're a screening site and you're to not wait for symptoms but to screen regardless of reason for visit, we still have some providers who are uncomfortable with that or who maybe haven't bought in themselves, and so those one-on-one visits gives us a chance to kind of give them the maybe information about other sites and how it's happening there, give them an opportunity to express those concerns or those fears, and for us to be able to address them or at least hear them out, because those are some of the things that, although they can be challenging, are really important, because if the provider doesn't want to do it or doesn't believe in it, it's not going to happen. That's a lesson learned that I'll highlight later, but it deserves stating here. Also, we provide them feedback on data. We have a new system that has been created through our Child and Adolescent Health Center in their consulting work, and they are just now coming up with a new data system, actually, that's a web-based data entry system for these screening sites. And that web-based data entry system not only collects information, and it is done in a, what do I want to say? It uses a unique identifier, so it doesn't include identifying information, but it does collect information about positives and negatives and who's tested, but it also does collect behavioral information and information such as that reason for visit. So we're able to analyze that data, and it is fed back to the site so they can see the reality for their venue, and they can also compare it to the reality across venues. Something else that we've done to try to increase coverage in these screening sites is we've increased their allocation of tests. The Adolescent Health Program does support the sites, but through the purchase of some tests, and those are both for the test sites as well as the screening sites. But STD has also supported these sites by giving them additional test resources. Again, they're the totally appropriate target population for IPP, particularly the females, and so it is a tie-dye of resources from STD and from Adolescent Health that provide the allocation of tests for these venues. The venues that are screening sites, again, they're in high morbidity areas, they are seeing high positivity, and so basically our agreement with them is that throughout the year, if you are running low on test requisitions, call us, we will get you more because of who they are and who they're screening. We also do presentations at coordinators meetings. I think Lisa spoke about doing training with these staff from the site type, and so we also do presentations at their coordinators meeting that occurs annually, and I will be doing that in just a couple of weeks here. So, all right. Seems you guys are having a conversation in the chat side, and that's good stuff. Let me know if I need to respond to that, or Sandra, I'm going to hold you to letting me know what questions I have at the end, okay?
Sounds good.
All right, thanks. All right, so our second strategy beyond just expanding coverage in our current sites was to select new screening sites and to what I call flip some of our test sites to screening sites if they fit criteria that we wanted them to, meaning that they were in high morbidity areas, that they were already proven as a site that could test and had opportunity for volume, and that they also had high positivity. So we really wanted to make sure that we were getting the most bang for our buck as we were making these selections. In 2008, we were looking at data, and this again happened at one of our statewide alliance meetings. We were reviewing some data and talking about who do we think might be a good screening site, and collectively this is one that popped out to us. And this agency, it's Detroit Community Health Connection, which is a federally qualified health center, is the parent organization. The Adolescent Health Center is called Healthy Teen, or Yeah, I think that's the total name of it. Their nurse practitioner I want to acknowledge and is here on the screen, Marie Shoulders-Williams. She is a dynamo. She is committed to this project. She's committed to screening the youth that present to her in her clinic and very much on board with the philosophy and the work that we're doing. This center is located in Detroit, and while it is not on campus of any one school, they are actually what we call a school-linked site, and they serve as the school-based health center for 11 Detroit public high schools. So in calendar year 2008, they did 357 tests. 22% of their 22% of those tests were positive for chlamydia and 6% for gonorrhea. So very high positivity. Our average in the state, again, for chlamydia is just over 10%, and for gonorrhea at that time was just over 4%. So we identified them as a site that had great potential and that we wanted to flip into a screening site, meaning that we would provide them with extra resources and attention, and we would particularly give them additional resources for screening and treatment. By doing that, by counseling and by the consultant working with the nurse practitioner, in calendar year 2009, they more than doubled their screening. They did 908 tests at just this one venue, and those tests were obviously among 13 to 20-year-olds. And 16% of those tests came back positive for chlamydia and 4% for gonorrhea. So again, we saw a slight drop in positivity, but given the number of tests that were being done, we were bound to find people who didn't have infection. But the reality is that we found 144 cases of chlamydia and 36 cases of GC at just this one site. And so we think that it was a great choice and a great site to move into this program. In the coming year, in the coming school year, we have a couple of new sites that are going to be added to our screening list. And again, those sites and the sites that we added last year are in high morbidity counties and parts of the state in public high schools. So we are seeing the right venues, and now we just need to work with each of them individually to get them screening and screening regularly. Marie Shoulders-Williams is an example of where as soon as we flipped her position and we gave her more testing resources, she was ready to go and more than happy to do the screening. So we had no buy-in there, I should say. She was right on board and was able to hit the ground running to screen this 918 people last year. So the question that I see here is, what do you think are contributing factors to high GC-CT positivity rates of Michigan teens? That's a big picture question, and the reality is that we have we have high positivity kind of across the board when you look at gonorrhea. We do have some of the highest rates in the region. We thankfully are seeing a drop, but when I'm speaking about these screening sites particularly, when I speak of them as being in high morbidity areas, they are areas where we see particularly the influence of health disparities and histories of racism that are really impacting positivity in our urban centers in southern Michigan. And those urban centers have kind of a large bolus or amount of disease that has been there historically and that continues to pass. And so all of the reasons and all of the things that contribute to health disparities contribute to our ongoing fight against chlamydia and gonorrhea here in Michigan. All right, so the last strategy that we included in increasing the number of youth who are screened is to develop a guide to implementing a sexually transmitted disease school-wide screening. And this guide was part of our plan that we presented to the legislature, and because of that, when we first received our funding, we did contract with a consultant to help us to pull it together and to write it. Our administrative staff here at the state STD program is 3. So we are pretty limited, and so we were able to hire a consultant, thankfully, to help us to pull this together. In hindsight, this is a tool that there are other examples of out there, but we were not aware of them at the time, or they kind of had passed through people's vision, and I, being new to the program, was not aware of similar projects. The advantage of doing it here in Michigan is that we did have the opportunity to pull all these resources together and to make sure that it was legal and appropriate information that we were providing to Michigan providers. So this is kind of the cover of our guide, and I'll talk a bit about the content in a minute, but it's also bookend here on this slide with a graphic from the School District of Philadelphia, and that is because I want to acknowledge that in starting to prepare our plans around school-based screening and blitzing, I did have the opportunity to learn a lot from Melinda Salmon from Philadelphia Department of Public Health, and she was very generous with their materials, with their information, and a lot of that is seen and reflected in the guide to STD school-wide screening here in Michigan. Again, in hindsight, I realized that it wasn't new or news, but it is hopefully something that's helpful for our providers here. The document contents, I'm just going to hit these really quick. The facts about STDs, chlamydia, and gonorrhea. We started with that not because we felt like the providers who may be reading this didn't know it, but we did it in a way that the information that's included in the manual can be provided to schools or to parents or to other groups where the screening entity may be trying to gather buy-in. So it was done in a really kind of basic language and basic information so that it could be used with various stakeholders. The second section of the document is gaining school and community support. Then participants in school screening. One thing that we wanted to highlight here in Michigan was that the site doesn't have to have a school-based health center on site to necessarily do a blitz. And we want to encourage others to consider how they might partner with a high school to do a blitz. So the actual clinical provider, and as it's outlined in the document, the clinical provider may be the local health department, they may be a community health center in the area, they may be the school-based health center or the fiduciary for that school-based health center, or they may just be an interested physician. It doesn't necessarily have to be a school-based health center. It can be any clinical provider who is willing and able to partner with a school to do a blitz. We also have a section on project implementation, and that's that kind of how-to. How do you get the kids in the right rooms? How do you keep the flow going? How do you do it in a way that maintains confidentiality of the youth who are participating? And what are the components of the blitz? We include educational materials so that they can be utilized, again, at the time of the activity and without the person who's coordinating it having to think all this stuff up or go find it elsewhere. We have a section on giving results, providing treatment and follow-up. What are the recommendations and ways to do that? Again, maintaining confidentiality, considering your partnerships with whoever is actually doing the screening and how to make that all happen. And then we have a section on evaluation and funding, acknowledging that oftentimes if you are working with a community partner, maybe there's a university or some other health entity that would like to do the screening, but it has an evaluation or a research component to it. And although that's not the push of this document in any way, we did include some tools there that may be helpful in evaluating the activity for future knowledge gained. And then we have a section on lessons learned, and those lessons learned came not only here from Michigan, but also from other programs that have done screening across the country so that people, again, don't have to kind of come up with all the information on their own. And then we have a resource section that includes information on sample consent forms, sample educational materials, and section with the laws here in Michigan about adolescent confidential services so that people have it all in one place. All right. We had this great experience here in Michigan in that as soon as we released this document, or almost kind of simultaneously as we were releasing it, we had something that presented itself as what I'm calling the quick win at Detroit Finney High School. And this was a school-based health center with a practitioner who had been screening at very low rates. They were averaging probably about 8% of their student body was being screened. And the nurse practitioner just kind of had a light bulb go on one day. And as it had been kind of the idea of having a blitz had just been being kicked around at meetings, at events, and conversations that we were having as it related to the GCCT reduction plan, but the document had actually not formally been released yet. But through a partnership between the School and Adolescent Health Centers and Finney High School, they went ahead and pulled together a screening. They had the advantage of being actually a school-based health center that has other school-based health centers in other schools. So their parent organization is St. John Health Center, and St. John runs other school-based health centers. And so Finney brought in providers from a number of other clinics to be able to do a screening or to do a blitz. And they did use some of the resources from the guide as far as ideas about how were they going to get the kids in the right place, how were they going to maintain confidentiality. And this is while this is the only blitz that has occurred to date, it also is a great example because the data that came out of it is compelling and pushing us to try to get it into other areas. So what did we see? They screened not only the youth that attend Finney High School, which I should state is a high school in the northeast side of Detroit. It's in the city of Detroit. They screened their day students, or the students who attended the school during a regular school day, and they also screened students who came to the school for alternative or night school. Based on life situation, the kids in the alternative night school would be probably categorized as higher risk. They are often people who have dropped out and have come back to try to complete their GED. They may be young women who have children who have dropped out of regular day school. They are kids who have gotten kicked out because of problems with discipline. So again, by definition, these alternative night school kids, they have a little more chaos in their life and by definition may be at higher risk. Collectively, through the Day and Night Screening Project, they screened 306 youth and they found 8.6% positivity for chlamydia. The positivity was a little bit lower than we had anticipated, but the coverage was great. And at 8.6%, it's nothing to scoff at. So who did they screen and how many did they screen? In the day school population, they screened 64% of the day school students. And again, that compares to 8% in the year prior. And of the night school students, 83% chose to be screened. If you look at the positivity for chlamydia, you can see that it's higher across the board in females than in males, and higher in the night school population for both males and females than in the day school population. As far as asymptomatic infection for the chlamydia, those who tested positive for chlamydia, only 8% of the males reported having symptoms, and 29% of the females reported having symptoms. So 90% of males and 70% of females who were identified in the Blitz as positive for chlamydia were asymptomatic. Very important. Very important. Another important piece of the puzzle is that those who chose not to be tested didn't need to be tested by and large. This slide shows that those who chose not to be tested in the day school, their average number of lifetime partners was less than 1, and the same was true for the night school population. The average number of lifetime partners for the day school overall for males was about 4 and for females was just under 2, and those were the kids who chose to be screened. So if they had had more than 1 lifetime partner, on the average, they chose to be screened, understood their risk, and were screened. Likewise, in the night school population, we see a higher percentage or a higher, average number of lifetime partners for females in the night school program over 4 and for males over 5. So what is necessary in order to have a successful screening project, a school-based screening or a Blitz event? What we know is that it requires a clinical partner, and I've talked about that could be one of many types of clinical partners. And the other thing that it needs is it needs to have a willing and brave school system. That has been really the challenge for us here in Michigan, is because there are a lot of questions around liability and concerns around parent response to doing a school Blitz. And so it does take both sides of that equation to be able to do a school Blitz, and so that's a piece of the puzzle that we're working on here. What we've learned is that stuff is easy, meaning we in the STD program and with our partners in school and adolescent health, we can provide support in terms of tests that are necessary, requisitions, lab services, medication for the positives, sample forms and tools. But that's not the hard part. The hard part is getting that local buy-in and getting the school that will say, we're willing to help. With the screening project at Finney, one of the reasons that it was allowed to happen and it was successful is because St. John Health System, who actually runs the school-based health center there, took all liability and responsibility for the event. Finney High School was definitely took a back seat in the project and into the screening. They allowed it to happen, but if there were any questions or any concerns, they were referred back to St. John Health System. So, again, that's just a piece of the puzzle and that we realize causes people to be skittish. There's a question, I'm sure I've missed some here, but by looking at enrolling additional sites in the screening project, how does this impact current sites? And In general, the answer is that it doesn't. Their position remains as long as they are continuing to screen and we're seeing positivity coming from those sites, they remain on the roll as a screening site. As I mentioned, we did have the one location that was in a rural area that had very low positivity, and they were removed from the screening criteria or screening group. Do any of the school health centers offer HPV vaccine? I'm sorry, I don't know that answer, but I can find out for you as well. All right, so successes and challenges here in Michigan. A couple of things, and I know we're getting short on time, so I'm going to cruise through this pretty quickly so that we can get to any other questions that happen to be in line. But again, we've had a great success at Finney where we saw that the students were willing to be screened, and particularly those students who had risk factors in their life, who had more than one sexual partner. They acknowledged their risk, they were willing to be screened, and we were able to screen them and provide treatment, which was so important. Based on the success of that project, we do right now have interest being presented from St. John Health Center to do a Blitz in the coming year in one of their other school-based health centers at Highland Park High, which is an extremely high-risk community. Highland Park is an island that is surrounded by the city of Detroit. It is a city of itself, but it also is surrounded by the city of Detroit, and it's very small and very financially disadvantaged. And so we're hopeful that we'll be able to do that screening in this coming year. Other parts of the state and other areas that we're exploring, we have a partnership with Muskegon County Health Department. They have been working with a local school there for a couple of years now, trying to kind of, get the buy-in, get all the people on board who would want to be involved in that process. Initially, the school was like, nope, we don't want to do this. It's not about us, and we're not willing to step out on this. They have had a change in their administration in the school and also in their school nurse, and so the health department now is hopeful that they will be able to take another run at it and perhaps be successful. Benton Harbor School-Based Health Center is a school-based health center down in the southwestern corner of Michigan. And the reason that I included them on the list is really my wish, not necessarily theirs. This is a school-based health center that was experiencing positivity around 20%, and a couple of years ago they lost their fiduciary. The clinic closed for a number of months. And it has recently reopened. They are screening, and they're upping their screening, but they're still screening a relatively small number of people overall. And so to be able to do a Blitz there, I think, would be important because there's probably a lot of kind of backed up infection, if you will, from not having screening occur there for a number of months. And then Calhoun County Health Department is a local health department who already has a relationship with their school-based health center in their public school. But that public school, again, is not screening a super high proportion of their students, and the county health department is interested in partnering with them. So in the coming year, my program, MDCH, is going to be trying to broker a relationship between those two entities to see if we might be able to do something there, because both the school-based health center and the health department are very interested, and we're hoping to be able to work with them to expand that screening. So what are we going to be doing going forward in Michigan? First, we're going to continue to focus on coverage in our screening sites. In addition to coverage, we're also pushing retest, a 90-day retest for students who test positive, and raising awareness and knowledge around that for our providers in our school-based sites. And then also encouraging and supporting through tools and messaging the inclusion of information around partners and making sure that partners get in for testing and treatment in our current screening and testing sites. We're also identifying new screening sites. I mentioned that we have a couple of new ones coming on this year, and those sites are chosen because of the morbidity, the background morbidity in the communities in which they reside, as well as if we have any data about their past screening or testing practices and what the positivity rate was. And all of that is taken into account, again, in our partnership with school and adolescent health centers to be able to select good sites for screening sites. The last thing that I have there as a criteria for that is staff enthusiasm. I think that we have learned collectively over the last few years that, again, we can think that they're a perfect site to be a screening site. We can think that they have, super high positivity. Of course they would want to do this, or, given the positivity. But the reality is that if the staff does not feel able or willing to be a screening site, then all of our enthusiasm goes out the window. And so we really do have to consider kind of where is that staff coming from before we present them as a screening site or provide them with the extra resources that come with being a screening site. And then we will be building on the success at St. John Health, as I mentioned, to hopefully do that Blitz in Highland Park. And we will continue to highlight our successes in publications and presentations such as this. My hope is that we can build a little bit of internal competition among our school-based health centers and also among our public health partners to see if we can screen more high-risk youth in Michigan. Our take-home messages is that the most important thing about our screening in Michigan and what makes it as successful as it is, and hopefully will make it more successful as we go forward, is our relationship with our community and adolescent health center staff here at the statewide level. They are able to institutionalize screening in their sites by things in their contracts, by their messaging with their venues, because they fund those sites. The STD program has no, if you will, jurisdiction over those school-based health centers, but these sites are funded through the adolescent health program, and so they can institutionalize their expectations around screening through their contracts. We also want to work together with that entity to make data-driven decisions, again, about which sites should be screening sites as opposed to continuing some level of support for sites that do testing of primarily symptomatic or high-risk clients. And then we also want to acknowledge that the document, such as our screening Blitz document, is just one tool. It's not a silver bullet. We have not seen the number of sites pick up screening that we hoped would occur, but it is an opportunity that's out there. It is a tool that's out there for others to use. And the most important thing is a provider with a mission is a strong thing. So a quote that I found that I thought is relevant to what's happening here in Michigan, it says, "Keep on sowing your seed, for you never know which will grow. Perhaps it all will." And so that's why we use our multiple strategies, including our screening and testing sites, as well as our Blitz, and trying to encourage that in more venues, so that hopefully together these sites will be able to increase our number of youth who are screened. I want to acknowledge our partners at the Child and Adolescent Health Center program, also the consultant to the program, Linda Beyer, who contributed data and just tons of hard work with our screening sites. The screening document author, Jennifer Salerno, who also does blitzes in her own school. Our epidemiologist, Katie McCumber, and our STD acting manager, Chris Judd, for her support of the project. And my contact information is included for any questions that we're not able to get to today.
Thanks, Amy. It was great to hear how you guys are truly able to invest in your testing sites and provide as many kits necessary by enriching resources and working with other sections in the Department of Community Health. So thank you for sharing your story with us. So we now have 11 minutes. Oh. Okay, well, we went quickly. We'll go to the poll, and then we'll go quickly to Q&A. We put up a new poll. For those of you who don't screen in schools, how interested are you in starting a program? Go ahead and complete that. We'll give you a couple of seconds. Okay, I'm going to go ahead and skip to the results. I'm happy to see that after both presentations, you're still very interested in starting a program, and that's wonderful, wonderful news. So we're going to go ahead and do question and answers. I think both presenters did a fantastic job of following the chat as they could. There are a few questions that were specific to Michigan. There's a couple of questions that I think would be applicable to both, so I'm going to start with those, but don't worry, I'll try to get to as many as possible. So one of the questions was, what suggestion do you have for implementing screening in a conservative school system?
Do you want me to take a shot at that?
Sure.
Okay. I think that a couple of things in hearing, again, from some of our school-based health centers and from some of the staff. We haven't had a ton of sites do a Blitz, but there's also, sites that are just doing testing that even have to consider this question. And a couple of the things is, one is to use it to frame chlamydia and gonorrhea screening, one as truly as a health issue as opposed to a sex issue, and to be aware of the data in your local community. Data can be very, very helpful. If the data is that you don't have very much infection in your community, then a screening may not be the best approach, but having testing be available may be all that's necessary. Another thing would be to see if there's somebody perhaps on the Sexual Health Advisory Committee or maybe the school nurse, somebody who is well respected in the community who does agree with this approach as well, and to use them as an advocate or as a voice for the project to gain more input and to gain more buy-in, if you will, would be another strategy that I would encourage, is to use somebody who's already has respect in the community or respect of the adults and the parents in that community.
Great. Lisa, do you have any suggestions regarding implementing screening in a conservative school system?
Well, I think it goes for any school that you're going to have the best success if you have a champion for the project, usually somebody at the school who wants to see it done and will kind of lead the charge, get the buy-in from the administrators. And then when you have all the data to support it, and sometimes you just can't get it and you have to walk away. But
Great. One other question was, what worked best to get parents on board with screening? Either of you can take that question.
In some of the schools, the LSU staff did presentations for the parents if they would come. And of course, when we were doing it, the parents had to provide consent. So educational materials were sent home with the consent form.
Yes, and that has been, again, in similar programming here in Michigan, is that it's not uncommon to offer a parent education opportunity associated with the event, but that what we have found is that actually participation often is very, very low. But in Michigan, in our document in talking about how to do a blitz, we do recommend. We don't, of course, we don't mandate, and it's going to be up to each jurisdiction to decide what works for them. But we do recommend and provide guidance on how to do an opt-out screening, meaning that a letter goes home to every parent about what is going to happen, about the education, about the opportunity for screening, how results will be delivered and treatment, and that it's basically, please, you need to fill this out and sign it if you do not want your student to be involved in it. Otherwise, they will participate. So that's the approach that we try to do here in Michigan.
Okay, great. One of the questions in the chat box was, have either of the presenters considered social marketing campaigns to continue to engage students beyond mass screening days?
I see that Lisa is acknowledging that they do in Louisiana, and she can talk about that a little bit more. We have in Michigan just this year, for the first time, kind of in an orchestrated way, if you will, picked up on the GYT campaign and tried to extend the use of that in our school-based centers and also in our local public health centers. And they are using those materials, many of the sites, throughout the year and not just using it during April. So we have used that as, if you will, free opportunity to use a social marketing campaign that's been developed for the target audience and encouraging that use.
And actually, we have not in Louisiana, but that is an excellent resource and a good idea.
Great. Okay, some of the questions I think that I missed further, or that may have been missed further up. I believe, Amy, when you were presenting, there was a question about providing screening in juvenile detention centers.
Mm-hmm.
Do you guys do
we
that?
We do provide, or excuse me, we have screening in juvenile detention centers. We have 9 centers, all in high morbidity counties in the state, that we support with testing resources, again, test requisitions, lab services, and medications if they have any problems getting medications if necessary, and they provide the staffing, obviously, for that. So those are another venue where we see very high positivity and lots of asymptomatic infections. So they're an important partner for us as well.
Okay, great. And another question was regarding partner follow-up. Do school-based staff, are they trained to provide partner services?
Not in Louisiana.
Yeah, I think specifically not in Michigan either. It's something that we have been looking toward and working with our training center in Denver to possibly do a shortened training. I also know from our regional partner in Illinois that they have some online training, and so we're exploring ways that we might be able to borrow some other training resources to extend that to our school-based health center staff, but to date that has not been a specific training that we have done.
Sandra, there was a question about rescreening, and
yes,
it made me think about, we have this guide that actually was developed by our school-based health center arm that funds those sites. It's called Best Practices for Prevention in School-Based Health Centers, Screening for Chlamydia, Gonorrhea, and Other STDs, which I believe I could share with anybody that wants it. But it does recommend that students who test positive for chlamydia or gonorrhea undergo a complete exam if they haven't already, looking for physical findings, other symptoms, be offered testing for HIV and syphilis. Females should get a pap smear and should be assessed for the need to rescreen according to the CDC guidelines.
Yes. And here in Michigan, our guideline around retesting is that any male or female who has tested positive for chlamydia or gonorrhea should be retested. Our recommendation is at 90 days. If they do not present or to come back at 90 days, whenever they're seen in the next 12 months, they are to be retested. And we allow our sites to use our prepaid test requisitions for that retest.
Okay, great. And the final question I'm going to ask is from the chat box. What activities are done to educate students about the importance of screening?
Pretty much it's through the counseling that the workers in the screening program or the school-based health center provide.
Yes, and in our directions on doing a Blitz, it does include education. And while Lisa spoke about in their model, they do one-on-one counseling with every student. At Finney, that was also the model that they used. I believe they did like a group education. They would bring a whole classroom of students down to the health center, do some group education, which included information about screening and the importance of the test and why it was being offered. And then each student did meet with a school nurse, at which time they answered questions, asked, collected other information, and that's when the student made the decision whether they were going to screen or not. So that the importance of screening is included in all the education associated with this activity.
Great. Well, thank you both for providing some wonderful presentations. Thanks to everyone on the line for attending. I hope everyone found this webinar to be as interesting and as useful as I did. We have our final slide. This is the first in a series. Our second webinar will be the good, the bad, the ugly of going big, a behind-the-scenes look at the school-based screening program in Washington, D.C. That's in exactly 2 weeks. You can still register on the registration link at SurveyMonkey. And finally, we absolutely need your feedback. As we mentioned at the very beginning, we couldn't have done this without our CDC DASH funding, and we want to be able to continue to provide such events for you if you find them useful, which I certainly hope you do. So please click on that link. And again, we'll send out the link for the evaluation with the link for the archived webinar. So what will be in the archive is the audio recording of this presentation, all of the slides, a transcript of the chat, and we'll also, the presenters and I will take a look and make sure that we gathered, answered your questions, any resources. I know someone asked about Amy's Michigan guide that she referenced in her presentation, and we will blast that out to you guys. So thank you so much. Have a great afternoon and rest of the week. Thank you.
Thank you. Please stand by.